So let's talk about fluid imbalances. What happens is the fluid doesn't stay in the appropriate compartment? Remember that 20% of the body weight should be in the extracellular and then 40% should be in the intracellular, comprising the 60% of water that is our body. But what if it doesn't stay there? So first spacing is what we call it when we do have that normal distribution of fluid in the ICF and ECF. The fluid is where it is supposed to be. However, what you'll see is that we can actually have movement that is inappropriate, and that would be called second and third spacing. So second spacing is more typically called edema, and you may have heard edema before. Sometimes you'll hear it called swelling. Usually when we refer to it as swelling, it's related to trauma, so that's kind of an emergency room term. Outside of that, especially if it's cardiac in nature and or a fluid balance issue, we do tend to refer to it as edema. And what edema is it's that abnormal accumulation in the interstitial fluid. And so instead of having fluid where it should be, either intracellular or in the other extracellular compartments, in particular that plasma, that intravascular space, it actually moves into the interstitial fluid, and then we have that puffiness, that edema occur. Third spacing is a little bit different. Third spacing is where the fluid moves primarily out of the vascular space, but it moves out of the intravascular space into an area where you can't easily get to it. So it'll move to the pericardial sac, the sac that surrounds the heart. More commonly, it'll move to the peritoneal cavity, so patients who have what we call ascites, especially with liver failure, it can even move into the pleural or the lung cavity. So that fluid moves to an area where it's not easily accessible, and we kind of can't get it back once it goes there. Once it goes there, we have to get to it externally through the body. So for example, in the case of peritoneal fluid, what we need to do is actually access it with a needle and drain it externally through the skin through a long tube. That's a slightly different procedure, and we'll talk about that when we get to liver and things like that, but I think it's important that you recognize an example of what transcellular space would be. So let's look at the patho. When we look at tying this all together, what we'll see is that if the plasma moves to the interstitial fluid, that shift results in edema. And that results in edema because you see elevation of hydrostatic pressure, that's the push. You see a decrease in the plasma oncotic pressure. Remember I had referred to albumin as the water magnet? Well, if we have low protein, low albumin, we're not able to hold on to that fluid that should stay in that intravascular space, and then it can move out into the interstitial space. We can also see elevation of interstitial oncotic pressure. So the interstitial themselves actually start pulling on people. We may also see some obstruction of lymphatic outflow that can decrease the amount of fluid that is actually removed from the interstitial space as it should be. So you're starting to see how important those basic concepts of diffusion, osmosis, hydrostatic pressure, and oncotic pressure are. They really relate to what goes on in our body on a very regular basis. Now the other thing that can happen is that the interstitial fluid moves into the plasma. And what happens here is that the fluid is drawn into the plasma space because you have an increase in the plasma osmotic or oncotic pressure. And sometimes this is simply based on osmosis. And this is a really good example of albumin. And an example of osmosis is we put someone with compression stockings on. And one of the things it does is it literally manually pushes the fluid in where it should be, out of that edema space, that second space, and back into the intravascular space. So your book does a really good job, and I just wanted to pop this up here so you could take a peek at it, that they really do talk about common causes of edema, and they group it slightly differently. They talk about increased capillary pressure, they talk about decreased colloidal osmotic pressure, and that's that albumin, that protein, that pull. They also talk about increased capillary permeability, and this is something we'll talk about as we move through more complex topics, and then again, that obstruction of lymphatic flow, which I've mentioned here and there as we've gone. So when we think about fluid shifts, I'm hoping you're figuring out that we can have too much fluid and we can have not enough fluid. So I want to clarify a little term. Porth does not go into this distinction, but I think it's important from a nursing perspective, and nephrologists everywhere will thank me for teaching you this. That volume deficit really refers to an abnormal loss of body fluid, inadequate intake, or a shift of fluid from plasma into the interstitial fluid. So we're literally having that shifting occur. out of plasma into interstitial. That plasma, that intravascular space, remember back, I said it's that 5%, that's where the money is. That is our circulating volume. When we don't have sufficient circulating volume, we move into a volume deficit state. Dehydration is a little bit different. Dehydration is loss of pure water alone, but you don't see the corresponding loss of sodium. And so what happens is if you remove the water and you don't remove the sodium with it, you actually have high sodium. You actually have hypernatremia. And we're going to come back to these concepts again, specifically when we talk about sodium, but I just want to plant the seeds that we're really going to be talking primarily about volume deficit, and then I'll weave sodium in here and there as we go. So what causes volume deficit? Increased insensible loss, increased perspiration, increased urine output, and there are several things that will do that. We're going to talk about DI in just a little bit. Osmotic diuresis, overuse of diuretics, and diuretics are agents that we give primarily to our cardiac population to have them release water. And so from that perspective, overuse of that can lead to increased urine output. We can also have bleeding in the form of hemorrhage, GI losses, whether that's diarrhea and or blood. We can have someone who has a volume deficit because they're not taking enough fluid in, but we can also have someone who has a volume deficit. They are intravascularly dry, even though they may have fluid stuck in their abdominal cavity. They may have fluid stuck in those hard to reach third space areas, but it's not accessible to the circulating volume. And so those are patients we need to really watch because they look like they have a boatload of edema on and they've gained a lot of weight, but they're carrying that fluid in an inappropriate space that is totally inaccessible by the intravascular space, which is where our circulating volume is. So what does the patient look like with hypovolemia? They look restless, drowsy, lethargic, confused. They tend to be dry. They have a volume deficit. So they have dry mucous membranes. They may be thirsty, which is a good sign. Decreased skin turgor, so they don't have that rebound they should. They can even have some changes in their capillary refill. Now, low-grade fever and increased respirations, tachypnea, are things you may not think of, but those can happen as well. They can also have changes in their blood pressure. For example, when they're sitting and then they move to standing, and that quick change, you can actually see a drop in blood pressure if they don't have that circulating volume to compensate for that change in position. When you don't have volume, you don't have extra volume to give, and so your kidneys will adapt to that, and you'll have decreased urine output, and your urine tends to be more concentrated. Weakness, dizziness kind of fit in with all that. Weight loss, again, we'll talk a little bit more about weight, but basically 1 pound or let's say 1 kilogram is 2.2 pounds is approximately equal to 1 liter. So when we're talking weight loss and weight gain, we're looking at approximately a kilogram to equal 1 liter. Now, hypovolemia can actually lead all the way to seizures and coma. And so these are things we're really not joking about because of the decrease and the risk of what happens with decreased cerebral perfusion. So the top of that restlessness, drowsiness, lethargy, and confusion, neurological, and then that can move all the way to seizures and coma. So when we talk about what does the patient look like from a lab perspective, there are some differences between males and females. We're not going to stress those. They're subtle differences. But what I want you to keep in mind is that if we have someone who has a volume deficit, meaning in that plasma, in that intravascular space, we draw blood from them. What we will find is we have stripped away water, and so all of the other elements that are supposed to be contained in that plasma appear to be higher because there's less water to dilute it. And so they will have an elevated H&H, hemoglobin and hematocrit. They will have an elevated BUN, which is blood, urea, nitrogen, and we really don't call that BUN, just an FYI. We do call it BUN. That will be elevated. And then really, they're going to be more concentrated in their serum, in their plasma, in that intravascular space. And I hope you're hearing me intentionally use those 3 words to describe that space. That is how we refer to it. And so what we're looking at is that they will have increased osmolality, that tonicity, their concentration will be greater than 295, which is abnormal, that is elevated. The other thing we'll see is that their specific gravity of their urine. So once the patient, everything else, those first three are really referring to what's going on in the plasma, but the urine is related to they don't have any water to give. And so their urine is more concentrated, and we'll see that because the specific gravity, which is the measure of concentration, will also be elevated. Other labs we need to consider is we are going to take a look at their sodium, because remember, is it a complete volume deficit or is it dehydration? One involves sodium, the other does not. So typically we may see a serum sodium, but we may not, depending on which of those things is occurring in the body. And we want to look at their albumin and their prealbumin. Those are the water magnets. If those are low, that's what could be one of the reasons they're not holding on to fluid, and that is why they will dump that. And so prealbumin is a major plasma protein, and it's a really good marker, as is albumin, of nutritional status. And so prealbumin is an even better indicator, but both of them are excellent indicators of fluid status, and in particular nutrition status. So the nursing question I want you to always ask yourself, even when we're doing something like PathoPharm, is I want you to ask yourself, what does my patient look like? And then follow that question with, what am I going to do about it? So when we talk about fluid volume deficit and collaborative management, we need to identify the cause and treat it. And we need to give the patient fluid in most instances. Now, we may give intravascular IV fluids right into that intravascular space if that's where they need it. But really, we like to use natural whenever possible, and oral is the best. We're going to monitor their weights and monitor their eyes and nose. We had talked about balance through that pipe. And we mentioned the weight, that a liter is about 1 kilogram. We're going to watch their diuretic use. We're going to consider what can we do with sodium, and that will make a little bit more sense when we talk about sodium. And because they're dry, we really need to intentionally do good oral care, especially in a patient who is ill and unable to care for himself or herself. And that's basically what we're looking at with a fluid volume deficit. Now, fluid volume excess is the converse of that, but there are some nuances. It's not an exact opposite. So let's talk about this. So with volume excess, it can be the result of abnormal retention of water and sodium in about the same proportions in which they normally exist. It can be because of excessive fluid intake, or we're just hanging on to more fluid than we should. Kidney failure, heart failure, both are regulators. And if they're not functioning appropriately, we can actually have abnormal and inappropriate retention of fluids. And the other thing we can have is we can have so much fluid in our intravascular space that the fluids just start shifting. They move from the interstitial into the plasma, and we are just overloaded in an intravascular state because we're not able to get the fluid out of there, and or with chronic renal failure, we're not able to pee it out. That's what we should be doing, and we may not be able to do that. So let's go back and tie this together. The primary thing I want you to keep in the back of your mind is that we do need balance in our body, but remember that the money, our circulating volume, our usable volume that controls blood pressure, oxygenation, and everything else is at intravascular space. That is really where the money is. So we talked again about first spacing, second spacing, and third spacing, right? So we had talked about this. When we talk about second and third spacing, this is primarily useless fluid. And this is a very important thing to keep in mind, that if your patient has edema or they have third spacing where the fluid moves into that useless interstitial space, it is useless fluid. They may weigh more, they may look more, but they can actually still be intravascularly dry. So the patient looks like they're fluid volume overloaded, but they're dry intravascularly. The fluid is being stored in an inappropriate place. That's one of the things that makes this a little bit trickier, because when we talk about fluid volume excess, we consider the whole body, but we also need to intentionally consider the intravascular space. So it's a little bit different. So what causes this? Sometimes it's just regular old increased water intake. Sometimes I had mentioned those regulatory mechanisms aren't working, and we'll talk a little bit more about corticosteroids. Generally speaking, corticosteroids are very bad for us long term, and I know that's not very technical speak, but they really are bad. And we'll talk about these. You'll see that corticosteroids will come up in multiple places as to why they are bad and how they are bad, and I'll defer that till a later time. But really what we have with fluid volume excess is we have too much fluid on board, and you can have that fluid in your whole body. You can be intravascularly wet, but you can have that fluid overload, and you do need to make sure that you are fluid overloaded intravascularly as well. So what does your patient look like when they truly have hypervolemia? They can have edema or ascites, which we had talked about. Ascites is in that peritoneal cavity, and then edema is really anywhere else, that second spacing. They can have very similar neurological symptoms to what they had with hypo. But what happens is, let's say they do have intravascular volume. What'll happen is they actually developed JVD, jugular vein distension. You'll actually see bounding vessels, bounding pulses, and their vessels will actually bulge in their neck area. And they'll do that because of that increase in volume. The heart is working harder. It becomes more visual. You're more able to visualize it. You may also see, because they have so much fluid on board, they may be trying to compensate. And they may be peeing, and they may have very dilute urine. If, however, that doesn't work, one of the first places fluid likes to back up inappropriately, it will move to edema and it will move to interstitial. The other place it will move, especially if those places are full and or it happens quickly, it will move right to your lungs. So you will actually hear fluid. You'll hear it through what we call crackles. They may develop a cough. They may have dyspnea, which is shortness of breath. And basically they develop edema, but it's pulmonary edema. And all of this hypovolemia can actually manifest itself as weight gain always. So what does their blood look like? When we draw from that intravascular space, it's going to be the exact opposite. Instead of there not being water, so everything looks high, everything is going to be diluted. So their H&H actually look low. Their BUN is actually low. Their urine specific gravity is actually low. And then the sodium level really depends on the underlying cause. So we're not going to spend too much time, and we'll spend a little bit more time when we talk about sodium. So that's what my patient looks like. So what are we going to do about it? We need to do daily weights. Always remember that 1 kilogram is 1 liter. We're going to monitor eyes and nose. We're going to really watch sodium and fluid restrictions. And this is very patient dependent on exactly what's going on with them. But we have to protect their skin because those edematous areas are very prone to breakdown. We don't want them standing long times because what happens to that fluid? It just puddles in their feet. And we need to mobilize that fluid to excrete it. We may give drugs to do that diuretic I had mentioned. And we really want to make sure their heart and kidneys especially are working appropriately. So we may actually give drugs to increase their cardiac output. Now this is all further complicated as we age, because as we age, we have structural changes in our kidneys that decrease our ability to conserve water. We have hormonal changes that impact on ADH. We have a decrease in ADH. We have a decrease in antidiuretic hormone. We need to monitor that. We also have loss of subcutaneous tissue, so they have increased loss of moisture. And then they have reduced thirst mechanism that results in decreased fluid intake. So when you think about all of that, and we already said that they have less fluid, and so when you think about that chart, the child was very full, 80% fluid, and the adult was average 60, but as we age, that decreases. None of this helps. So we do need to watch the hydration status of our older population very closely. And we also need to take into consideration their simple functional ability. Can they get up and get a drink? Are they able to express feelings of thirst? Do they recognize that, you should be peeing regularly? Are they not peeing regularly, and are they not drinking because they don't want to get up at night to pee? Those are all things you have to keep in mind. They are much more susceptible to alterations in their fluid volume balance.